All right, I think we will get started. So I think most of you know who I am by now, but my name is Erica Baldry. I am the Infection Prevention and Control and Healthcare Associate Infection Section Supervisor for the State Health Department. Welcome to the Montana Antimicrobial Stewardship Coalition call. This is our April call. For those that haven't done this quite yet, please type your name, position, credentials, email, and facility affiliation into the chat box. And this is for grant purposes. And if you aren't from Montana, we do ask that you just include which state you are from. And then if you'd like to, you are more than welcome to turn your webcam on. All right, Jenny, you want to go to the next slide? I don't know if that one's updated, but if not, no worries. So today we have a really special treat for you. We do have a case presentation from JC Ott, and I'll let her introduce herself, and then we'll go into discussion and Q&A. If we have extra time today, we do have a presentation from Dr. Q that we can go over as well. So we'll just kind of leave it up to how things are going and what kind of discussion is happening, because as you guys know, we really want this to be an educational opportunity for you on the call, and really to take lessons learned and apply practices within your own healthcare facility. So, JC, I will turn it over to you.
Awesome. All right. Look for the green button. Green one. All right. Can someone give me a thumbs up? That would look good. Maybe we're ready to go. There it goes. There it goes. All right. We good, Neil? Okay. Thanks, Jenner. All right. So I am the ID pharmacist at Billings Clinic, and I work with the stewardship program. So if you're a provider, put your pharmacist hat on real quick. So let's see. So we'll get started. Find my mouse. All right. So we had a 65-year-old female come in on February 16th. Her past medical history: she was hospitalized from January 27th to February 11th. This is a little oversimplified, but has recurrent ovarian cancer, had some debulking, had urine leaking through the rectal cavity, had some nephrostomy tubes in place, also had a giant hematoma, and they had placed a drain. And then she was discharged. So 5 days later, she comes to the outside hospital with a cough and some purulent discharge from the drain. The outside hospital sent urine cultures, CT scan, so pelvic abscess. The drain wasn't actually in the cavity, and they said, oh, you go to Billings Clinic. So then she was brought here where we did the initial surgery. The admitting service put her on some Pip-Tazo. We need to update our dosing protocol, but currently it's set at 3.375 Q8. We use extended infusion, so 4-hour infusions for this pelvic abscess. And then the admitting team, which is an oncologic service, decided we don't really know what to do with pneumonia. So CT looks like there might be some pneumonia versus atelectasis. So they called the internal medicine residency service and said, you guys treat the pneumonia, we'll treat the pelvic abscess. On physical exam, though, she wasn't having any chest pain, no dyspnea, no sputum production, no wheezing. Lungs were clear. She had good saturations. She just had this cough. So the internal medicine residency service did a little bit of chart digging and like, well, she just had pneumonia in January, which could explain her imaging. And she had 7 days of ertapenem for E. coli pneumonia, which is an interesting plague. We'll talk about that. So they were like, it's not pneumonia. She had already been treated. This could just be radiologic clearing from previous ones. So she's on Pip-Tazo for this abscess. So we're going to call it good and signed off. So to go 48 hours, we get urine cultures back from the outside facility showing some ESPL E. coli. Blood cultures are negative. And the drain culture here at Billings Clinic was showing an ESPL E. coli. And so I put this up just to show you. So we have the outside facility shows their entire panel of susceptibility. So MOXCLAV and sulbactam shows susceptible, pointing out that subtriaxone is showing as resistant, ciproquinolones are resistant, trimsulfa is resistant at the bottom. Deaminoglycosides are susceptible. Those are not my favorite drugs. And then carbapenems look pretty good here. And then the key that tells me this is a urine culture is that nitrofurantoin is displayed. And since that's only used for UTIs, it should only be displayed in urine cultures. Keeping in mind this probably isn't just a UTI. So oversimplification of the hospital course, we had, they consulted IR because the abscesses weren't that big, and they said, they're too small, we can't put a drain in, so now we're gonna treat pelvic abscesses with just antibiotics, we can't create source control. Patient still had small amounts of fluid draining from the rectum and from this drain that was in her hip. She'd been afebrile for about 48 hours, so the team decided to put her on oral antibiotics. And so the discharge summary from the 21st, which is over the weekend, so we don't catch these. There's a lot of points that we'll talk about, room for improvement. They said culture return to E. coli sensitivities complete for the both left hip drain and the Foley. They say oral sensitivity to augmentin. And so they switched the patient to Moxclav on 2/19 after completing 48 hours of Heptazo, and then was discharged the patient for 14 days of PO antibiotics. So do we have any pharmacy students on, Jenner? It's fine if we don't. It's hard to get participation, so I like to usually pick on pharmacy.
Yeah,
students.
sorry, I was muted. No pharmacy students today, but I will show this to them later.
Oh, that's sad. Okay. So we'll have a little bit less participation unless anybody wants to participate. I did not have time to build a Kahoot, which would have been more fun. But I'm behind, I'm sorry. So does anyone want to take a stab at how they would define ESPL? We use this term a lot. We're like, ESPL E. coli, but like, what does that mean? Okay, so we'll kind of talk through a few definitions, because defining the definitions is really important. We throw around a lot of these words and ideas, and sometimes I'm totally guilty of this, not remembering to go back and like making sure that everybody understands what the definition we're using is. So ESBL is simply an abbreviation for what we call extended spectrum beta-lactamase. And so by definition, third generation cephalosporins are our extended spectrum beta-lactams. And so when we get what we call an extended spectrum beta-lactamase, it's taking out and inactivating most of our penicillins, many of our cephalosporins, by definition, taking out the third generation cephalosporins, and then oftentimes it takes out potentially aztreonam. Many of the ESBL organisms that we're going to talk about do retain activity still against carbapenems. We have a different term when we start talking carbapenemases. We call those CRE, carbapenem-resistant Enterobacteriaceae. And if they're producing the carbapenemases, we call them CP, CRE. It's a whole alphabet soup. We don't see a lot of that in Montana, so really we're just starting to see ESBLs here, especially since we've started to see COVID like ruined our susceptibility. I have no words. So a couple of other things, some of these ESBLs can retain activity to non-beta-lactam antibiotics. So checking for things like quinolones, trimsulfa, aminoglycosides. I have qualms with like some things that happen with that, and a lot of people don't know how to dose them. And so the four organisms that we really talk about, these ESBLs, and when we talk about the micro in a second, usually we're looking at E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Proteus mirabilis. Not to say that other organisms can't, but these are the four most common that we see with this beta-lactamase. And so ESBL testing is interesting. I don't know, it's been about 10 years. They changed the ceftriaxone breakpoints. So ceftriaxone is our third generation kind of poster child. Some places use cefotaxime, some places use ceftazidime on their microcard. They used to have high breakpoints up at what we call an MIC of 8. And then they changed that to 2 to try to catch all of these ESBLs. So in the old days, if they had like this intermediate MIC to ceftriaxone, they would have the microlab would have to do this additional testing called clavulanic test. And then they were like, well, let's lower the breakpoint. You don't have to do ESBL testing, which I think from an infection prevention standpoint kind of drove people nuts, because you worry about bugs passing this to other bugs and spreading this resistance mechanism in a healthcare facility. And so people were like, oh, like we can't let go of that. So some facilities, including Billings Clinic, we've kept doing our ESBL testing. Other places have gotten rid of ESPL testing. So when I talk about ESPL testing, some of the new automatic cards can do this. And then the way that it's done traditionally is you can use cefotaxime, ceftazidime. So those are the discs at the bottom of this thing. And so obviously if you put those on the plate, you put your lawn of your organism, it just walks those discs right off the plate. Clearly that's not susceptible, but if you use clavulanate or clavulanic acid, which is a really good in vitro inhibitor, so you add a little bit of clav to the discs and then you get expansion, so you get a really nice zone around your disc. So it's what we call traditional ESBL testing. Okay, so when they drop that breakpoint of ceftriaxone, so the breakpoint's the last point in the lab where it's considered susceptible. So when they drop that in the package recommendations, they said you don't technically have to ESBL test anymore. We do it sometimes for epidemiologic purposes, for infection control purposes, and sometimes now with all the new drugs, like I want to know the mechanism of resistance, but we can, like, that's a very specific thing we do in IV, and we kind of nerd out over some of this stuff. Some ways, if you don't have actual ESBL testing, that you can look at this is looking at your susceptibility profile, and we call non-susceptibility to ceftriaxone is often used as a proxy for what ESBL. So an MIC of 2 or greater to ceftriaxone, we infer a lot of times being concerned about ESBL. Now, that being said, there are some other mechanisms that can be, but for most of your E. coli, Klebsiellas, if they have an MIC greater than 2, a lot of times you are dealing with an ESBL. I think it's something like 96, 98% of the time in the United States. So it's a decent proxy to use. So just very much depending on what your lab has capability of. I'll tell you, it's kind of a pain in the butt to do ESBL testing. It's probably one of the least favorite things of our microtechs. They do, of course, because we ask for it, but we also have a little bit more staff than some of the more rural facilities. So some places you will see won't do actual ESBL testing. You'll see this ceftriaxone resistant as surrogate marker. And interestingly, in the literature now, when we're looking at studies with ESBLs, a lot of them will use the ceftriaxone MIC of 2 or greater as a surrogate marker, and the studies are actually ceftriaxone resistant E. coli, Klebsiella, Proteus studies as a surrogate marker. Sorry, that's a really confusing topic, but we'll talk about why this is super important in a minute. So since unfortunately I don't have any pharmacy students to pick on, so we kind of talk about this word ESBL, and then I go through this resistance mechanism, but why is this important? And so kind of some things to think about as we walk through some of the recommendations for treating ESBLs is amoxicillin clavulanate appropriate to use in vivo for an ESBL? Clearly, we use the clavulanate in vitro to show ESBL production, but does that work the same way in the body? And then the second follow-up piece to that is, does the location or site of infection change your answer? Does it matter where the organism is located? So a fun thing that came out, they've talked about these guidelines quite a bit last year at ID Week. So IDSA has formally had some living guidelines that have been updated and posted. It took them from like October, where they talked about them, till March to get them posted. And it's called AMR Guidance. The first document focuses on like ESBLs and some difficult to treat Pseudomonas. And then they have a second one that was recently updated, maybe like a week or 2 weeks ago or so. And that one includes some other types of resistance mechanisms. The nice part about these is they're living documents, so it does look a little bit kind of less traditional, I guess. As if you say it's like that double space where it prints like super long and it's really annoying. But it does live on the IDSA website. And so it's always easily accessible, and it's actually fairly straightforward. So there's like a question posed, an answer posed, and then their data as to why. And it's actually really cool. So I know everyone laughs, but in the ID world, ID Twitter is a big deal. And a lot of the authors are actually on Twitter. And so we've been able to have interactions with them like, hey, like, I'm just curious about why you picked this, or can you help me understand this? And they've been super helpful. But I don't think we've done a great job at publicizing these guidelines and some of the recommendations that are in them. And so I wanted to run through real quick, what do the guidelines say about ESBL treatment? And so we have uncomplicated cystitis, which is a very generic term. And so they have preferred treatment options of nitrofurantoin, or we call it trimsulfa for short, or Bactrim or Septra, very much depending on where you're at. So I usually call it trimsulfa because trimethylene sulfamethoxazole is a very long thing to say. And then in the guidelines, they give you a couple of alternative options. And so thinking back to our patient who they looked at the urine culture and applied the urine culture to pelvic abscess. So in our patient doesn't have really uncomplicated cystitis, so this is not necessarily appropriate options. But interestingly, in alternative options, they do list a MASC clad, but there are very big cautions associated with it in the guidelines. Higher failure rates were seen when they did it versus a 3-day course of Cipro. That being said, if you have 60-year-old patient, outpatient, there's some potential arguments. Their success rate was about 55% with this. So not always great. And then single dose aminoglycoside therapy, which is probably an unfamiliar concept to many people. Looking at oral fosfomycin for E. coli specifically, quinolones, carbapenems. On the flip side, carbapenems are only IV, so that's always usually not an ideal option either. So a couple more options for oral, but as you start to get to the more complicated disease states, some of these things where we have a bigger window for failure rate are not appropriate. So when you start to talk about pyelo and we're going deeper into the body, we need better blood levels, your options become more limited. We start talking about things like carbapenems. And then if they're susceptible, you can consider quinolones, which are great drugs for these. They have really good blood levels when you give them orally, and then trimsulfa. They do give some alternatives for complicated UTIs or pyelo, so aminoglycosides. And then there is a comment on fosfomycin for prostatitis. That's a complicated regimen, and it ends up being very expensive, and insurance companies will give you a whole lot of flack for trying to do that. You can get it done, but it does take some prior auth, and it's a pain in the neck. But it's certainly more fun than trying to give someone aminoglycosides and other things with PICC lines. So it's a possibility. And then when you get outside the urinary tract, you really get much more limited options for these organisms. We talk about carbapenem, so ertapenem, meropenem, imipenem, cilastatin. And then the alternative option is there's aminoglycosides. Super. So it's not a ton of great options. And what if you have an allergy? They do tell you that once you've obtained clinical response with these organisms, so your patient has bacteremia and then they start to improve, you can step them down to quinolone or trimsulfa if they're susceptible. So it's really important to get your susceptibility with these other agents. So let's go back to our patient. So this is what was displayed in the urine culture from the outside facility, which does display the whole thing in our system. And so the person who was discharging the patient was like, oh, there's an S next to amoxicillin, and that's oral. But if you go down, you've got ceftazidime, avibactam, which is only IV agent. Ertapenem's only IV. Gentamicin has topical formulations that don't count in this scenario, so it's only IV. Imipenem, mirovibactam, nitrofurantoin. But again, this is not really just urine, and nitrofurantoin is only if you have a bladder infection. Anything higher than that, it's not effective. And then potatoes. So everything else on this list is listed IV. So they were like, oh, it has an S, so we can use it. And so we'll talk a little bit about microcascading and displays. But first, I kind of want to pause really quick because we're talking about ESPL testing and all these things, which is getting phenotypic susceptibility. But now we're moving into this molecular era where we have other tests and we get these molecular tests. And okay, so we totally love to nerd out about this in our office. But we have some new technologies that we use BioFire at Billings Clinic. So if you have blood cultures, CSF cultures, I really want the lower respiratory panel. We're not quite there yet. And there's upper respiratory, there's some other things on there. So on the blood culture panel, so on the right side, we have some of the gram-negative bacteria. So your blood culture goes in the incubator and then it goes off and they gram stain it. And they're like, okay, yeah, there's organism there. Patients have super high white counts and stuff, and the machine will set off. So the gram stain it, they're like, oh, it's a gram-negative rod. And then they go and they put it on our BioFire film array machine, and it's a PCR technology. So we're using molecular diagnostics. And if it's one of the organisms on this panel, it will give me the bug name. So let's say it tells me that's E. coli. And then on the left side of the screen, BioFire can pick up certain resistance mechanisms. So CTXM is a type of ESPL. It's the most common in the United States. So the cool thing is, not that we have a lot of ESPLs, but every once in a while I'll be like, E. coli, CTXM positive. And then you're like, okay, pause. Like from a stewardship perspective, that's a huge thing for me. Like, does my provider know what CTXM is, first off, which I'll tell you most of them don't. And then we need to get guidance in the computer about what to do with that. And so really partnering with your lab, with the stewardship team to help providers know what to do when they see things like this. And so we're actually getting ready to revamp our micro stock here. And so if I bring this up, this patient didn't have positive blood culture, so molecular testing would not necessarily have helped us in this setting. But we certainly do say patients with positive blood cultures, they do have a lower respiratory panel. So if you're using that, these resistance mechanisms will show up. And I just put the carbapenemase here just as an FYI. That's way beyond the scope of what we're going to talk about today. But if you would like to nerd out over that, I would love to talk to you. So CTXM is not the only type of ESPL that we see in the United States, but it's by far the most common. So just because BioFire doesn't tell you there's a resistance mechanism doesn't mean it doesn't exist. So there's a little bit of guidance from the group called CLSI, Clinical Laboratory Standard Institute. They help publish, they meet annually, they publish their recommendations annually. They look at a lot of PK/PD data and how that works in vitro and in vivo and help give some testing recommendations. Labs can validate these recommendations and implement them in clinical laboratories. So we tend to follow CLSI recommendations. FDA eventually comes around, but sometimes they're a little slow. And so it has some stuff on molecular testing. And just to point out, like, molecular testing is really cool. We get really excited. We're like, yeah, I can put the patient on the right thing right now. But we still need to go back and do the phenotypic testing. So your traditional testing. So right now we have a Vitek machine that's ancient. We're going to get a microscan machine shortly. And so we still, even though the genes are identified, we're going to go back and still do our phenotypic testing. But they do give us a couple of options here, you know, obviously report out your phenotypic testing, but sometimes if you have molecular panel, you should maybe tell the providers, provide guidance. And so there's a couple of extra comments that they have, you know, susceptibility for ESPL carrying organisms can vary to beta-lactam combinations. So some of those might be helpful for providers when really I just want to put in the chart, if this is a serious infection, like put the patient on the carbapenem when we do molecular testing. So these are things to think about when you're working with your lab. What displays to the provider and how can we drive practice? Could we have driven practice in this other patient potentially better and driven them towards appropriate therapy in the first place when obviously they're talking pelvic abscess, augment is not appropriate. So we talk about driving practice, by the way, data is displayed. I only pulled one article because I could probably bore you for hours. There's so much literature now about like how we can drive practice by what we display in the computer. And so this one is one of the more recent articles published in 2020 looking called Out of Sight, Out of Mind. So these guys went about, they wanted to say like, can we reduce our cefepime? We're using so much cefepime and they started to get real nervous about it. So can we reduce our cefepime? So what they did was they looked at their gram-negative bugs, and when they were ceftriaxone susceptible, cefepime doesn't show up in the micro. Because right, out of sight, out of mind. And so often providers are like, oh, it tells me it's susceptible in the lab. And you're like, yeah, but we don't need to use something this broad. And so they took their cefepime testing out. So the column on the right-hand side shows what antimicrobial agents without a cascade. Otherwise, they would just report the ceftriaxone. Cefepime doesn't show up and meropenem doesn't show up. And what they were able to show was that if the providers didn't see the cefepime, they forgot about cefepime. And so their cefepime use was decreased. It didn't change patient outcomes. It didn't change mortality. It didn't change their readmission rate. So they weren't harming patients. But the other thing they found was that they got patients discharged faster. And the reason probably is because when we have ceftriaxone, right, we don't quite have oral equivalents, but we do have third generation cephalosporins that are oral. So keeping somebody on something so broad when we don't need to, maybe we can help get them out of the hospital faster. So sometimes we can use some of these pieces with the lab to help expedite and get patients out. It's kind of a neat concept. It's complicated. I will definitely give you that. And so the other thing that kind of came out that I didn't realize, so we really started looking at our micro lab here. We're updating our systems in April, which terrifying to no end because it's going to be a huge uplift. But what I started looking at, like the CDC actually came out with some specific recommendations. So I thought these were really cool to share. Looking at how do you bridge micro and stewardship and how can they help each other. And so the first one of I just cut a couple pieces out of this. The whole document link is there. I did find this really helpful. So talking about educating clinicians on how to interpret reports. There's a whole lot of new susceptibility categories in coming out for providers. And so this is one thing we're talking about. How do we educate our providers? Now I don't just have susceptible, intermediate, and resistant. Now I've got susceptible, intermediate with upcarrot, and SDD, so susceptible dose dependent, and resistant. And then they're like, what do I do with it? So we're talking about how do we roll this out to providers? How do we display these things in the computer? What can we do to help people understand the differences? They also put out a selective reporting stewardship susceptibility testing, like a primer for a stewardship program. So if you're just looking out, this is a really nice link giving you the information for that. A couple other things they put in there that I kind of liked, just really just partnering with your lab, working out the susceptibility of the organisms. And then micro labs should result susceptibility in a way that encourages appropriate antibiotic use and de-escalation. And so this was kind of interesting. One of the hospitals, the number 3 there that's cited, they went back and they, instead of putting usual respiratory flora, like on your sputum, we put normal flora. They went back and put usual respiratory flora, and then in parentheses it has no Staph aureus, no Pseudomonas, to try to help providers understand what normal flora means, i.e. your patient, if they have normal flora and they didn't grow these other bugs, they don't need cefpime and MRSA coverage. And so that was kind of a neat, and they were able to show how they could get providers to de-escalate faster simply by changing the language that's displayed in the computer. Then there's some other things that I'll tell, some other examples I'll give you. So they talk about automated instruments using expert rules. So some of this your lab probably already does. We're in the middle of changing processes in our lab. So we're back to the basics, trying to figure out like, what are we going to suppress in the lab? And so that's been a really interesting conversation on the back end versus just showing everything on the panel. How do we drive practice with this? Some organisms are intrinsically resistant. So for like example, Cyanotrophomonas, we don't show many drugs because we don't have many drugs on our panel that can actually work against that organism. And then some of them, a lot of this has to do with the older data. For ESPLs, I don't know, like 10, 15 years ago, if your bug was identified as an ESPL, your automated machine would take all the beta-lactams and make them resistant, period. End of story. Now with breakpoint changes, and we have some better testing capability that's not necessarily recommended. But if we're trying to drive practice certain ways, sometimes we just pull those pieces out and don't show them. And I'll give you an example in a minute. You can add comments to your susceptibility report. So for example, with Enterobacter species, there's really good data that 3rd generation cephalosporins are not a good idea. You can actually harm patients, called de-repressed AMP-C. And so for Enterobacter, maybe considering a comment, 3rd generation cephalosporins are not recommended for serious infections with Enterobacter. And that's evidence-based. In our institution for blood cultures with Enterobacter, we don't show 3rd generation cephalosporins because we don't want to encourage the use for that. Sometimes you can add comments. So like, for example, Staph aureus bacteremia, IV consult is recommended. That's really hard for some of the rural facilities that don't necessarily have IV on site. It's mandatory here at Billings Clinic. If you have Staph aureus in the blood, IV is going to see your patient. Like, that, end of story. And there's literature based behind that. It improves patient mortality rates are lower when IV is involved. So then there's a couple other selective reporting, thinking about where drugs penetrate. So on respiratory samples, we don't show daptomycin. Dapto is inactivated in the lungs. Let's see. And then the drug's not in the facility, we try not to show it. So if you have a whole panel of drugs, but you only carry like this many, showing that whole panel can sometimes get you in trouble, especially right now. We have a lot of locums floating through, and they're like, but it's on the panel. And so we try to suppress those and not show those. Okay. Sorry, this is kind of long. And so some labs, one of the things about Piptazo, there's a really big argument about Piptazo and ESPLs. I won't get into that. Some labs don't show that or put comments in that maybe that's not the best idea for blood culture isolates. And then some laboratories don't report the results of isolates that test susceptible to carbapenems. If it's positive for carbapenemase test, we don't have that problem yet in Montana. So we'll deal with that when those start to show up. We're going to live in our bubble as long as we can. And then cascade reporting is the last big thing this document talks about. The carbapenem stewardship, susceptibility testing. Results are not reported for E. coli if the isolate susceptible to ceftriaxone. So this is actually one of the ones that we're going to implement with our new system. And so I want to show you what we display our ESPLs look like. So I guess I'll just go real quick and show you the urine culture from the outside facility is posted on the right-hand side of the screen, and on the left side is what we post. So we really try to drive our E. coli ESPL practice, mostly pushing the carbapenems. Obviously, we cut out all the lower generations because we know that the providers probably shouldn't be using those especially for non-urine isolates. Unfortunately, this patient had a quinolone and Bactrim resistance, so you're kind of left with a few options, which if they had looked at the culture at Billings Clinic from the drain, they would have pushed towards the carbapenem. So you can definitely drive practice by the way you're displaying things in your laboratory. Okay, so let me tell you what actually happened with the patient. So they were discharged on the 21st of February, and then they had their follow-up with provider. They pulled the drain, they finished their oral antibiotics, and then 3 days later, patient spikes fevers, has fatigue, abdominal pain, doesn't feel well, presents back to that outside hospital emergency department. So they re-image the belly, there's new collections, there's a mid-abdominal subcutaneous tissue abscess, and they're like, whoops, go back to Billings Clinic. So transfer the patient here. This time the provider looked quite a bit at the history and was like, oh, this patient has a history of ESPL, started the patient on IV ertapenem. She wasn't septic, she was just not feeling well, did blood urine cultures, and they're like, call the infectious disease provider. So it's always fun when we get involved a little bit too late. There's some opportunity for retraining in this case. It's not really a surprise that her microdata grew her ESPL again. This time though, we've managed to make it angry. And so our MASC unison, peptides are kind of off the charts, which makes sense. She was exposed to a MASC. A MASC has good bioavailability, but your blood levels of beta-lactams, IV and oral, are like so different. And so to treat a pelvic abscess with a beta-lactam where you can't get great blood levels with oral is probably not a good idea in the first place. And then this is just an example of the more antibiotics you expose them to, the more selective resistance we kind of pick off in this case. The good news is on ertapenem, she Duffer-Vest, the IR is like, we can't drain anything. So we're still struggling with source control, white count got better, so and put on ertapenem, and we're doing CTs serially to watch that abscess get better. So to kind of summarize the things kind of wanted to bring up today, ESPLs can be inferred for certain gram-negative organisms by ceftriaxone resistant. So if you have a lab that's not necessarily doing ESPL testing, using an MIC of 2 or greater can help you be concerned that this might be an ESPL producing organism for E. coli, Club pneumonia, Club oxy, and Proteus. If you have known ESPL producing organisms for serious infections, we need to be very careful about which antibiotics we're using. Generally speaking, carbapenems are probably going to be your go-to. Certainly, if you get susceptibilities to quinolones, trimsulfa, you can step down to those agents when patients are improved. I wouldn't probably start that like in the ICU patient. And then using your microbiology suppression and cascading can help you drive practice. And so one thing we're working on is considering suppressing agents that would maybe be inappropriate for ESPLs from sterile sites. And as we implement our new microsystem, what that's going to look like for us. And so have any questions, comments, concerns, thoughts? I know Dr. Pugh probably has some.
No, no, it was an excellent presentation, and I think it touched on a lot of the points that we hope to cover for this whole webinar series. I think what I would like to add to this was that this is one of those things that many clinicians are not, well, let me step back, that how to interpret read and interpret micro reports and those antibiotic susceptibility profiles is something that we are not very well taught as clinicians. And many clinicians either and there's many approach to that, whether we could do the interpretative, that is susceptible, intermediate, resistant, which have pluses and minuses those, and then versus the actual reporting just the MICs. And that also has pluses and minuses to that. I could tell you from my experience seeing how clinicians use the actual MICs, they tend to just pick the lowest number, and that's how they decide which antibiotics to use. And clearly, there are flaws in that, especially if we're dealing with an ESPL organism. Now, let's step even a little bit further back. Clinicians love to use the term ESPLs, and even though that by itself means has a specific meaning, that's not the organism. And a lot of time I get a lot of annoying looks to me when I say ESPL what, because it's not just the ESPL you're dealing with, that the presence of an extended spectrum beta lactamase, but it's also the organism and where it's infected. And clearly here too is that certain that even though there that this E. coli strain is susceptible to other oral antibiotics as listed, but and that doesn't mean that just choosing those orals would be the right right regimen for that particular patient, especially in abscesses. So finally, the big challenge is to correctly identify ESBL producing organisms, especially for a healthcare setting, because these fall under the MDRO categories, and because of their transmit a lot of the genes at which produces these beta lactamase could be transmittable to other interbacteriales that you typically would isolate these patients until their infectious process has been appropriately treated. So there's a lot of challenges, and I think a lot of the points that JC had pointed out, something to take in mind, even though there's a lot to absorb, and I should kind of throw a lot, but I think the key thing is that it's correctly identifying ESBL producing organism influences patient outcome, as well as infection control measures within a healthcare facility. Any other thoughts, Vince?
Yeah, JC, great job. Thank you very much. Again, a tremendous amount of information there that's valuable. One of the questions that I had for you is, and you can comment on this, however, a lot of the smaller hospitals, the critical access hospitals, I think it's important to be able to engage with the laboratory and their laboratory personnel, because oftentimes it's almost like the pharmacy says, they're set aside, they're in the basement, they're in a different room, they're isolated, and so on and so forth. How do you suggest kind of creating that linkage between you and your lab so that you understand the language that they're trying to put on the chart or put out, so that it's how do you get out in front of that, so to speak? Is it one individual that you work with? Do you got to sit down on a weekly basis, monthly basis? Is it just how do you create that symbiotic type of a relationship so that you're getting the information that they want and they're not putting out a bunch of information that's creating some havoc out there? What's the easiest way that you found to get that done?
That's a great question. It's challenging. I will not lie. It very much depends. It's very hard if you're new. We've had a lot of turnover with COVID. And so that's been a bigger challenge. The most helpful thing, honestly, was for me to initially, set up a shadowing. Like, they love to tell people what they do. And so just ask them if you can come shadow them for an hour or two, just to see what they do, how their process works, how their process flows. Because your microsystem, like, for example, our microsystem is different than what's in our computer. And so that has to talk to each other. And so They love to show you what they do most of the time. And so the biggest thing is making friends with them, like take them coffee, take them donuts, let them know that like what they do impacts your job and impacts patient care. And so the biggest thing for me was initially, getting to meet them, spending time with them. And then we started doing like once a week, like, hey, on Tuesdays, I'll come down at 11 and let's talk about some things and bring a couple of like complicated patients, like, hey, this got resulted like super fast and here's how this impacted patient care. So they understood that their role was super important and it made them feel more like part of the team. So we started doing kind of a mini micro round, like, oh yeah, this blood culture, you guys like were able to biofire it and we got it in the chart within like 90 minutes. And this is what we were able to do with that information. And then we started meeting kind of on a more formal basis with leadership. After that, it really helps to know two kind of roles. The people in leadership who have the power to change things in the computer. IT is like, there's like micro pharmacy and like IT is like way over here. So it took us, we're not that great at it. We're still working on it for sure. But getting to know the leadership in the lab and meeting with them semi-regularly. COVID kind of threw us all together anyways. And so Neil has actually worked on a really good working relationship with them because pipettes are on shortage and we don't have tips and like, oh my gosh. So actually COVID's probably built the relationship even better because we've all been forced into this like shortage intense conversations very quickly. But take them donuts, go have lunch, invite them to the pharmacy, come visit, like get out of your comfort zone. Don't stay in your office.
I agree. I think that, just to follow up with what you said is, we tend to think of the lab as the separate entity within a healthcare facility. And there's just this mindless automatons where they just get samples, they do their thing and they spit out an answer, whatever you're looking for. And, and it is definitely, it's really worth your time to invest in building a relationship with them, because a lot of times you can refine the answers, a lot of those results, and get them to do reporting in a very specific way. If you had kind of get to know what they do and kind of collaborate to kind of work on improving patient outcome. Many of them are just I think that they're very welcoming actually from my perspective, that they're just because many clinicians, many labs are like our labs is in the basement. So they're just like, no one goes down to see them and they just feel very disconnected. But if you can engage, build a good relationship, you can, they're very happy to work with you to create something. And we can talk about some of the examples for diagnostic stewardship and things like that in help guiding and enhancing your antibiotic stewardship program. So just kind of wanted to kind of throw that in there. Now, I know some of your labs, especially for the critical access hospitals, most of your samples are sent elsewhere. Like, most of our, we get a lot of samples sent to us. So that may be a little bit more challenging. But even then, I mean, there are still ways what JC has presented as her examples, it's not just the only way, what you only things that you can do with the lab. There are a lot of many other things, but just kind of keep in mind that you should certainly keep them consider them part of their antibiotic stewardship team.
Yeah, I would agree, and my experience with them has been. And you made a good point there, JC, and I would reiterate that. It's go down there, and if there's something I don't understand, teach me, educate me. What does that mean? What is that, and how do I use that? And then you can kind of go back and grab your ID doc colleague, and so how can we use this better? And then once they become involved, it makes the stewardship process and principles much easier. So I agree 100%.
I'm going to ask a question kind of from the public health standpoint, JC, because I think a lot of healthcare facilities on here, and this actually might involve Kirsten and Dr. Koo as well answering, but if you do have a patient that's currently hospitalized and they have an ESPL, one, what kind of internal, communications occurring from the lab to infection control to the provider? Additionally, if this is a long-term care facility or assisted living facility resident, and say they're hospitalized, they get transferred, and you get the results after they've been transferred, how is that information being relayed to the other congregate care settings? So kind of twofold, but your internal processes, so your interfacility communication, as well as your intra-facility communication when you transfer outside of the facility.
I'm going to defer that to my IP colleagues. They are excellent at that role. Kirsten and Chris, are you on?
Yeah, hi there. I can start and then Chris pipe in, but we have some things set up internally. So let's start there. So, you know, communication, the lab I know does call the floor with the updated lab results, but there's some system generated isolation orders that will automatically fire in our AMR in Cerner. Okay, so that alerts the nurse to their taskbar that, okay, this person has something new that requires some form of isolation. Okay, so for ESPL, it would be contact isolation. And then to your second question, you know, if it's someone that resides at a long-term care facility and the test result, you know, results after they've been discharged, we will contact, infection control will contact that facility and let them know that test results. So if they're an organization that does implement isolation, that they can do that. So I'll stop there, see if Chris has anything to add, but I hope that helps answer your question, Erica.
So this is Chris, and that was good information, Kirsten. I would also say that, you know, if a patient hasn't quite left the hospital yet, you know, the care management team is looking at how that patient has been managed while they're in the hospital, if they're in isolation or not, and then they would clarify with us if the isolation needs to be continued when they're transferred to a different facility. So we just weigh in on that as well. That's another question that comes to us. So.
Thank you, Chris and Kirsten. I think that's definitely something when we've done our infection control assessments, a policy that we look at is, you know, what is your internal communication look like and what does your external communication look like? As many times, you know, these are patients that get transferred back to a different facility or something like that. And so just a friendly reminder to all of our facilities on the call today that you definitely want to make sure that communication channels being completed, even if, you know, they were at your facility, it's been resulted, but they're not at your facility anymore, letting those long-term care, assisted living facilities, rehab hospitals, that kind of thing know.
And Erica, if I may, I'd like to add, and I'm kind of going back to what I was saying about the identification. That's probably the biggest challenge most facilities have is do I have a patient who has a multi-drug resistant organism? And that's, you know, we are looking, you know, her JC's example was kind of prime because the clinicians who referred this patient to us initially didn't think of that. And a lot of that has to do with the fact that how the report, you know, many clinicians don't really, again, know how to interpret these results. And so even though there are a few R's that pop up there, it didn't click to them that, hey, this may be an ESPL producing organism. And then when they, and even when these patients get here, meaning our clinicians don't pick that up either. It's like JC picked it up, but the clinicians, admitting clinicians didn't really think about that. So that is probably going to be your biggest challenge is how do you pick it up earlier on? Because a lot of, you know, certainly this poor patient we ended up finding out about it after, or at least that care team found out about the ESPL producing organism after the fact, where the patient failed treatment, had didn't have a bad outcome, but definitely could have been caught earlier and then got on the appropriate antibiotic regimen. Also, this is an infection control issue, right? In that this patient should be in isolation, contact isolation. So therefore, there's that risk of potentially transmitting the genes or, you know, this organism to other more susceptible patients. So that's going to be the biggest challenge, and how to set up a good system to kind of pick this up. And there are algorithms that could kind of help with that. But as I said, you have to set that up, and based on if you have a lab that's able to detect, to do all the identification, or you have to send it out elsewhere, and you can't guarantee that sending a sample to a Mayo Clinic or to a Quest or LabCorp will automatically for them to tell you, oh, by the way, this is an ESBL producing bug. So you're gonna have to factor in that a lot of these results will have to be interpreted, and that part of the skill set of an antibiotic steward, someone in your team will have to have at least some of the skills to be able to interpret some of these results so that they can identify these bugs.
Yeah, Neil, that's a great point. You know, what I would add to that is I think we need to be able to archive that somehow, even if it's just one isolated case, and we see this once every 2 years, and remember that case that we had back. I think every case has to be documented and put in some way, because again, we're going to see it again, and how do we handle it again? So adding that to our learning skills, putting it in an algorithm, in a protocol, and some sort of a package, so that we remember it and we recognize it next time it shows up, and then we know what to do, as opposed to what did we do last time when that guy showed up like that. And I think we get right back to the scramble mode. So we got to be kind of stair-step our learning approach to it as well when these things pop up. So yeah, absolutely.
Yeah, and I think from an epi perspective, right, we'd want our facilities tracking these types of organisms. So if we do see a cluster or we do see an outbreak, that we're identifying it and responding to it appropriately. Because I think one thing, we also look at is one facility may have one, but that individual stayed at a different facility that has 6 or 7 or 8. And so being able to link all of those puzzle pieces together. And so Vince, to your point, tracking, documenting and having kind of a procedure that you follow is really helpful from the epi perspective as well, and from public health, because I would not investigate a single case, but if you saw a sudden increase, or we were concerned about transmission occurring, we definitely want to get public health involved at that time. And then I'd probably be bugging JC and Dr. Koo and you, Vince, and Jenner, so kind of the same crew. Any questions or comments from any facilities on the call? Have any of you seen an ESBL, or know what the lab report looks like? Or has your pharmacist ever come to you and said, hey, I think we've got something going on? Any experience with these? You can use chat if you don't want to unmute. And it's okay to say no.
I will give you a tip, like in whom you should suspect ESBLs. Certainly, you can kind of for those, like patients who are cancer patients are likely or have a higher risk of having these resistant bugs, not necessarily to be ESBL, because many of those, if they're becoming immunocompromised, they get blasted with antibiotics all the time. So you're probably going to, those are going to be one of those population that that you may want to kind of just be aware of, that they may carry some resistant organisms. From I'm going to assume the majority of you are probably dealing with more outpatient who acquired these bugs from an outpatient basis. And the quintessential, from my sample, of someone who actually usually presents with an ESBL producing organism is the elderly lady who get treated repeatedly for asymptomatic bacteriuria. And then you get they finally get a urine culture that showed this really resistant bug. That's usually what I see. And when they get referred to an ID clinic, and they get a little upset because we're like, if you have no symptoms, don't treat it. But that's usually where a lot of times I see, I get these referrals, is that from an outpatient setting, is those who get multiple treatment for UTIs or something like that, and they develop these bugs. So there are actually certain patients you can kind of suspect that they may carry them. But again, the hardest part is because we still don't have a really good standardized way of all the platforms and reporting to identify these bugs readily. Some are better than others, and if you're lucky to have a molecular testing like BioFire or Cepheid, yes, then you can kind of run this. But I mean, I'm not sure that it's really practical to run every sample with a gram-negative rod through this machine to identify those cases. So a lot of it will still kind of fall down to back to the interpretation of those antibody susceptibility reports.
Well, Erica, this is Kristen McNerlin at Billings Clinic. I was just going to comment, yes, to answer your question, we have seen some ESPL here at Billings Clinic. What I really appreciate about JC, because I'm big picture new to my role. I've been in infection preventionist for 6 years now. And, you know, we rotate we're a team of 4 over here, and we rotate our surveillance rounds every week. And we're looking at all these different cultures. But what I really appreciate about JC is she'll email us with a fin and say, this is a particular angry bug. So I'm learning what the word angry means. But JC, that never stopped doing that because I don't fully get it, okay? And so I just really appreciate when you do that for someone who's new to the role. So thank you.
Yeah, I think Jenner's my JC. So I get it 100%. I think that is 110% why it is so important and why CDC even specifically says having pharmacy expertise now, having that pharmacy expertise, you really do need it to have good stewardship.
It's all about the teamwork. We all have very important different roles, so we all work together. It's been really good.
Okay, we have 3 minutes left. Any final questions, comments, discussion? Looks like we were able to fill the entire hour as per usual. So Dr. Koo, we'll do your presentation at a different time, but I always appreciate your guys' feedback and your questions, and Dr. Koo and Vince, you guys sharing your expertise and your thoughts whenever we do have these case investigation or these case presentations. So any final questions, comments?
Just want to let all of you know that I posted the link to those to the IDSA practice guidelines for those resistant bugs on the chat. They're free for access, so you can just click on them. Hopefully that you'll find that useful. I don't know that this got sent out, but we also have I think I shared the link for the handheld app called First Line that will kind of offer some practice guidelines for what we do here at Billings Clinic of what we recommend for treatment, antibiotic recommendations and treatments and such for specific conditions such as community-acquired pneumonia and such. So if I think that was sent out, believe, right? So, but anyway, it's free to use for everyone. So you can just download it and just click Billings Clinic or actually any other facility for that matter and kind of see what they're doing. That's actually one of the nice big advantage of having that app is that we all share kind of what we do, but there are going to be subtle differences. So you can certainly adopt some of if it works well, you see if it works for you. So definitely download the app if you haven't done that and just to check it out. And finally, SHEA, the Society of Healthcare Epidemiology of America, or SHEA, has also offers some free antimicrobial stewardship educational sessions. And I know they do a couple of blurbs on YouTube about just some practical things about antibiotic stewardship. So it's another great resource to check out and kind of look at what other people are doing and and try to just make it work for your facility. Keep in mind, there's no one way of doing antibiotic stewardship. It's whatever you can make tailored to your organization and to work. And so don't feel like what we suggest here is the only way to do things, but you just have to a lot of it is trial and error. So, but anyway, and if you have any questions, feel free to reach out to me, JC, Jenner, Vince, or Erica, and we're more than happy to kind of help answer and help improve your antibiotic stewardship programs.
Thanks, Dr. Koo. Our next call will be on Wednesday, May 4th, so we hope you can join us. As a friendly reminder, our antibiogram survey for the Montana AMS program was due on the 31st of last month. I don't think I got an antibiogram from everyone, so if you could please send that our way. If you need help developing your antibiogram, Jenner can help with that as well. Just let us know, and we'll see you next month. Thanks all.